Can you move away from this screen?
AK is a 52-year-old full-housewife, a Muslim and Yoruba. She was referred to a teaching hospital for palliative care on account of excessive blood in bilateral advanced cancer. It was 3 years prior when she was found out with cancer. Long prognosis about 3 years ago when she commenced care at the General Hospital in Lagos. Care was transferred to a tertiary facility. She had 4 courses of chemotherapy and reported due to passive breakthrough complications evident by shrinking retinas. She supported alternative therapy and anti-oxidant supplements. 8 months prior to presentation, relapse was symptom setting, which prompted her to present at the teaching hospital in Ogun State, where she tried out 2 courses of chemotherapy and was scheduled for modified radical reception. She lapsed into unconsciousness following the induction for the FMC. All attempts to reverse the failed. She was intubated and nursed in intensive care unit for about 24 days. The patient was taken up about 6 days prior to presentation. No significant improvement was noted, hence referred to her facility for palliative care. Family members were said of looking at it. Family members were aware of the management of stage initial disease and post-maternal outcome. The patient was comatose. Husband could not go to work. One of the children who was supposed to have traveled abroad could not do so. They were expecting that she would recover. Her husband, an engineer, also managed a steel water factory. They have 4 children in a monogamous setting. The first of the children is a pharmacist. The second is an IT professional. The other siblings were still in secondary school. There is no family issue concern. Following the family comprehension of the need for home-based palliative care and the possibility of continuing the ICU care in our facility, the family decided to continue with care. She spent a total of 27 days in admission in our facility upon referral from the teaching hospital for home-based palliative care. However, at the point in time, the patient was discharged because of the industrial action and was referred to a private convalescence nursing school. She was readmitted to continue care in this facility after the industrial action was suspended. Patient was still unconscious following the return to admission in this facility with regards to this year of reevaluating. She was managed on the ward till she passed on. Principles of palliative care describe the problems facing Mrs. AK. Physical problem, she lost her breast. She has cancer. Then the psychosocial problem, family members were scared of losing her. The burden on the family members, everybody has to abandon their lives. People have to travel, they have to be in the hospital. And they also had denial. Family members were not. That's the psychological problem. The psychological problem, the family members were not denial. They were hoping that she was going to recover. Then the spiritual problem, she made several medical attempts. She did almost every possible therapy. She was an antioxidant, and despite her condition was going down. So I don't feel like despite all their efforts, that God will do the work. So to have some effect on their spirituality. But Mrs. maintaining palliative care, yes, that was why she was even referred from her other facility. Then communication, breaking values, unique and ethical issues. We use the SPAIN protocol to break the values of the setting, the right settings, and we ask for their perception yes, then we invite them if they are interested in going on, then we go and share knowledge to them, show empathy, and support. And when breaking values, we break it in chunks. We don't rush it, no distraction, and we show empathy. Pain assessment and management. Assess the pain managing Mrs. She was unconscious, like you said, already pre-rehabilitated, so she was probably not in pain. You
cannot do that to quantify the pain.
You cannot assess the pain, she was lying. So she did not express the pain. So we just give her like care for the dying, like just maintaining her dignity to the point of death, because she would not express much. And part 4, symptom management, pharmacological and non-pharmacological management. So the symptoms said she was already unconscious. We only give her like care for the dying. So we suction the secretion because of death ratchets. Then we use IOC for airway secretion. We give pills for dilation. Then dying people usually have agitation, some of them. So we can give haloperidol or other subcutaneous medications. Then we monitor the input and output. Then monitor vital signs. And it's very important to maintain dignity to the point of death. We don't just abandon them like this person is dying. Then times 5, identify the losses experienced and the help she requires. She was unconscious, she was dying. So the people that had the loss effects were her relatives, because they had to place their lives on hold, they had to stay around her, and the anticipatory grief, and she did so many, she put in so much effort, and then they'll be like, after everything, why does he have to end? Like, they were even in denial. So it was really hard on them. And the interventions, we invite the clinical psychologists to counsel them, and then their chaplain, the imam, the Muslims. So we'll just counsel them and just to restore their hope. Then cultural and spiritual care. The cultural care will just ask as healthcare professionals, like, is there anything, just give treatment according to their culture. Like if there's something they would like, or maybe the way how they would prefer to die according to their culture. And spiritual care will invite their imam. Members of the interdisciplinary committee that we mentioned the legal psychologists, the chaplain, the nurses, the doctors. Then describe your care plan for the CCK. It's just the nursing care, taking care of her, and that care plan, since she was like asked if there were advice, and if she cannot make decisions for herself, caregiver will do that. Sorry,
the family they do not want the woman to go. They do not want the woman to go. It was a very hard choice. So my advice would be to restore.
It's truly a very dicey situation. As an anesthetist, I know they put the patient to sleep and the patient did not recover. Why the patient did not recover? As previously overdose, patient no fit, multiple organ failure, the liver, the kidney, all those things. But we don't want to do it all those things. Patient was unconscious and was transferred to this place. Patient spent a long time in the ICU. And that's one of those things that we are advocating for. We have an aesthetics here. We have an aesthetics here. I'm the only one. I practiced anesthesia for 20 years. But I was doing an anesthetic service hospital. Where I moved to practice. And it is a pity they are not here. I would have liked to discuss with them. At the University of Namibia, my friend is a professor there, professor of anesthesia. They do a lot in ICU. And I've always been one of their facilitators teaching. Because now I told you, you can innovate palliative care to any level. There is palliative care in ICU. That's why we are discussing today. We have ICU here. Do they do palliative care? No. You see that people who are in the ICU don't need palliative care. They need. And of course, injury can testify to it and other things here. When the surgeons realize that the patient is not coping well in terms of pain management, they call us. We go to ICU to manage patient, manage the pain, what sort of pain, the social and all those things. So, palliative care in ICU is there. And of course, for an unconscious patient in coma, the ethics is there. So the ethics is, shall we continue or withdraw all form of management? So if you have a palliative care providers within the system, you're supposed to have an MDT meeting. What are the benefits of sustenance? Why should you let go? You understand? To what extent are we going to interfere? Are we still giving the patient nutrition? Are we still giving the patient antibiotics? Are we still giving the patient blood? You understand? All those problems are there. But unethically, because I think I've done the ethics in the head, on the scale of beneficial, malnutrition, you look at it. And in a developed world, there must have been advanced care plan. There must have been a living will. That's in my own presentation, but I want the word. A living will in the sense that by adventure, I cannot decide on my own the next type of therapy or management I want. I've decided, I've given this to Dr. Aguilara to decide on my behalf because I cannot talk. I'm a member of Advanced Care Plan International. I was with them last time in Ogun. But what's it called? The COVID step in and mess us up. It is the same everywhere. Nobody wants to give an advanced care plan. Especially with our own setting, the culture. How many men know that he's going to die and ask lawyer to come and do will? For part of it, I don't know whether it's only men that will do will. Do women do will?
Yes,
which women? So that's part of the problem we have here. People are secure a lot of things, and this advanced care plan works with you guys, especially. And you know there are some countries that they have legalized euthanasia. That's why I follow them. A lot of political people are here. Euthanasia is being practiced in some part of America, good in Canada, Netherlands, and Switzerland. But they know that there is nothing in it, and then we pray. I was at I won the fellowship, Palliative fellowship, from the Local Society of Medical Oncology. That was part of the in process in 2009. And after finishing with the Spodek Institute in Brussels, I moved to Switzerland We have European College of Oncology in Switzerland. And we always do one plan. In the morning we go upstairs, we see this woman together with the husband. The husband will excuse her. It depends on what was on 400 milligram morphine, and we still be looking at it. Not be swallow, IV, 400 milligram. Then one of these days I asked the consultant, what is happening here? He said that they flew in for euthanasia. They flew in to Switzerland for euthanasia. And those people who conduct the euthanasia, those people who conduct the death, it's like this period. I need to have the December period. In fact, when I look outside my window like this, they are freezing, no snow. So those people are going to do it, they have gone on holiday. December is going on holiday season. People in South Africa. So it is when they resume that they are going to do the killing, the massive killing. So we are all waiting. And these people, they are very weak, they are ready to go. You understand? Unfortunately, before the end of the holiday season, she passed on normally. But that will not happen in our own environment, the culture. We still believe our prophet said, he shall not die, but live. There is nothing you can do about it. So the best is just to continue. But when the patient dies, there is nothing you can do about it. But if you do it very well, you're supposed to have counsel enough with evidence. You're supposed to support them enough to find out the reality and accept. The acceptance depends on how much you are able to work with them. Communication skills. Sometimes you don't even win here. We give them the boost. The liver is gone, the lung is gone, the bone is gone. What else are you standing for? But they will still believe it can be done spiritually. And part of it, communication skill, never you take the hope from them. What they believe, let them carry on. But you said, but never take the hope from them and you continue to support them. It's more of ethics. But that was a brilliant presentation, understanding. We appreciate it so much.
Yes, what did
Case on the file. Mrs. Spain is 30 years old. She's married with 2 children, aged 4 and 7 years old.